Hello, my name is Carolina Varela. I am a physician at the hospital, I am a physician at the Quality of Care Unit of the Hospital Universitario 12 de Octubre in Madrid, Spain. I am as well a member of two scientific societies, the Spanish Society and the Madrilenian Association for Quality of Care. Thanks for watching. It is a pleasure for me to introduce you to this work titled Implementation Plan and Health Outcome Measurements Implementation Toolkit for Value-Based Healthcare. There is growing interest in translating value-based healthcare into practice to increase the sustainability of the healthcare systems. At the Quality of Care Unit, we have been working since 2018 in implementing value-based healthcare and changing the institution's paradigm toward measuring outcomes and value for patients. Our pilots for the moment have been breast and lung cancer within the voice community, inflammatory bowel disease within improved community, COVID-19, and age-related macular degeneration within the HMDMI community. After those 2 years of pandemic, the institution has decided to analyze the first year data. These results will help evaluate the impact and efficiency of the new technologies. We have as well analyzed and detailed the steps and tasks associated to each of those implementation steps. We want to share with you our good decision and our pitfalls as a guide for the institution in that wish to direct their mission towards value-based healthcare innovation. Due to the complexity of the implementation, we had to use several methods explained in detail in a specific publication or technical reports. One of them was a modified Delphi study with 2 rounds. Within this study, the consensus criteria was that there should be a median equal to or greater than 4 and a relative interquartile range equal to or less than 25%. We use as well semi-structured personal interviews. Within these interviews, the consensus criteria was the information saturation during the interviews. We use as well the collation of the personal experience on the implementation, experience with the implementation team professionals, and discussion groups with patients and professionals. The consensus criteria in the discussion groups was as well the information saturation. As per our experience and regarding the conceptual framework of the implementation side backing up the value-based healthcare innovation, it is important to understand that value-based healthcare is a real paradigm change affecting the whole core of the organization, and that it will suppose a change to the daily work, the continuous improvement circle, and the service payment methods, and therefore it will drastically change the managerial decisions. That means that some important cultural and technological adaptation have to be done. To do so, we recommend to plan an implementation in 3 main phases: the pre-implementation, the implementation, and the post-implementation. These phases has been explained in detail in another of our posters, and I'm not going to detail that much. But we have as well detailed the flowchart of the implementation phase, which is the one we wanted to introduce more deep in this presentation. So during the implementation, you have 5 sequential, more or less sequential steps that are communication with the working group and the institutional stakeholders, the appraisal of the innovation within the professionals and the patients, the preparation of the data and the tools, and also the piloting once we have everything set up to begin. So, as we see in the bottom of the figure, there we have drawn the flowchart representing the implementation step by step up to the beginning of the post-implementation phase. So focusing in the implementation process represented in the flowchart, we see to see the arrival of the innovation in 4 entries, basically: managerial department, hospital services, consortiums, and research projects. Once you have a project to be implemented, once you have a petition of implementation of one innovation in one of the healthcare processes, you have to prioritize these processes, because you can probably You can't probably give an answer to all the projects at the same time. So for this, we have developed a feasibility assessment tool and a complexity assessment tool that will help us to make the resource allocations. Once the decision is taken to continue with the project, there is need for selecting the leadership and coordination. Leadership has to be double from the managerial staff and from the clinical staff. The most important is the clinical staff, clinical peer, the clinical leader, but also to have a managerial leader is important to backing up the project. So once we have the leader and the coordinator normally is the quality of care professionals. In this case was me from the quality of care unit. But once you have the leadership and the coordination settled up, the technical works begin. And the process analysis, which is the first step, helps to understand where, when, who is the responsible, how you have to record the data that you will need. That include the clinician reported outcomes, the patient reported outcomes, and we normally try to do as well the patient experience reported measurements. Patient experience is not part of the value-based healthcare paradigm, but it has been shown more and more their utility as a method to improve processes. So once we know our process flow till now, we have to adapt the recording tools that we have because they are not always adapted to record data structure or standardize. So the first part is precisely that. We have to structure and standardize our data, and then we have to develop or adapt tools for recording and data extraction. That means several changes, including labeling patient within the cohort, have usable tools to introduce data in the database, including the patient reported data, which is not usually allowed in electronic health records. As benchmark is an important objective of value-based healthcare, we need to prepare the information to make it happen. So we need to normalize and standardize the data in a shareable manner and determine the visualization of the information in dashboards usable for clinical practice and benchmark. Adapting all the data and tools include the cost that often are not even considered per patient. After data and tools are adapted, people has to appraise the change and understand the new available tools. We can begin to, so once this is done, we can begin to outcome measuring for personalized clinical decision measuring value for patient, for healthcare, continuous improvement via benchmark, and for health technology assessment that will give us the clue as if it should or should not stay in the daily work. We have a structure and standardized 6 stages on the technical development of the project, as you can see up in the figure. In the bottom of the figure, you can see the flow chart that we just explained with the identification of where these stages or these project technical packages are implemented. We can say that we have 6 stages on the technical development of the project, or that we have 5+1. The +1 is the cross phases project management, okay, which is always kept along the process, the implementation process, I mean. These 5 phases plus this cross phases project management was obtained by consensus in the Delphi study, and are as follows. Phase 1, data readiness, structure the data. Phase 2, information system readiness, normalization and standardization of the system. Phase 3, data recording and extraction. Phase 4, data analysis and visualization. And phase 5, research and innovation. And of course, the 6th, cross-phase, cross-project management. As explained before, the bottom figure localizes the stages in the flowchart of the implementation process. The data readiness, structure, and normalize is performed and aligned with the process analysis where the exact way of collecting a specific data is detailed along with the person responsible of the recording tool and database for storing the data. The information system's readiness is detailed in the flowchart and has several main milestones: patient labeling and recruitment in the cohort, cron, prom, and print data entry, data normalization and standardization, data sharing and visualization. The data recording and extraction is the main part of the piloting and will fine-tune the recording tools for including the innovation in the daily work. After the recording begins, we thought all after the recording begins with at least a critical number of patient data, then the analysis and visualization takes place and helping clinical decision making and personalizing the healthcare to the patient, as well as allowing the research and innovation stage. The sixth identified stage occurs, as we explained, along the whole implementation process and should finish at the beginning of the post-implementation phase. During these years, we have, during these years, we have detailed the many tasks in each of these stages, as detailed in the figure. The cross-stage technical package will include definition of the project objectives, team governance and methodology, development of data management protocol and analysis plan, development of the internal and external communication plan, administrative management, including, for example, sending information to the ethics committee or looking for funding of some sort, protection of intellectual property rights where applicable, and monitoring and the project plan and deliverables. So most of these tasks we have already standardized a lot, the documentation and the deliverables. Data adequacy is a tricky and paramount stage of those projects, what we consider stage one. First of all, because they will help to make decisions for patient treatment, but as the information will be used for comparison and benchmarking, we need to make sure that we are measuring the same. But not only we are measuring the same, but we are measuring it in the same way. So we will assure a specification of the data set, the modeling of the data elements, a specification of terminology links, definition and validation of the standardized catalog and archetypes, training for healthcare teams on structured data recording with quality, and registry quality studies. It's important to define in this data adequacy phase or stage the data set with the professionals. I know normally we work with ICHON or other standardized and normalized data sets that came from an international consensus from Adelphi, but it's important for the physician, for the team, for the professionals to make the data set theirs, to appraise the data set. And if they need to introduce some other measurements that are not much in number, it should be allowed. Even though in the benchmark, we only compare the standardized data set indicators. On the other hand, one thing is to have data properly recorded following protocol, and different thing is having the tools to do it adequately. These tools have to warrant as well confidentiality and data sharing, and they should allow the interoperability with external platform or ICT tools. So it's necessary to review and create univocal identifiers of the variables, design and develop data recording systems, and make possible database integration, implement supporting tools for quality data recording, integrate the external collection tools. The tools have to allow as well the creation and follow-up of patient cohorts. Thus, we need to assure the capacity for labeling the patients and cohort creation. But we will need as well to make available tools for data visualization and follow-up, as for example, dashboards. We use here the Power BI. Once the pure technological challenges have been met, we need to make the recording of the structured data possible, and this implies a mix of measures on pure technological matters, integration of external collection tools, and some more organizational matters such as description and analysis of the care process, follow-up of cohort patients, follow-up of patient-reported questionnaire. Especially important is the follow-up of the complexion of PROM questionnaires that cannot be collected at times other than the one proposed. And it is important to review the quality of the data with systematic data quality audits, which imply as well to reach an agreement on the main dimension of the evaluate on the main dimensions to evaluate data quality. This would be the stage 3. And the stage 4 and stage 5 are the data analysis and visualization and innovation research. These are already the data extraction moment. And the stage 4 is mainly focused on data extraction for patient care, individual health care, and the stage 5 is more focused in population health or research, secondary use of the information. As you can see, for data analysis and visualization used in the healthcare process, we need to characterize the target population, stratify the cohort, and also determine clusters for analysis, find a way of automatic exploitation of data, data management and structuring and formatting of the data, statistical support, data visualization, provide clinical practice feedback to healthcare professionals, and benchmark with other healthcare organizations. As for the stage 5, which is more focused on the secondary use of the data, not the primary use as the stage 4, we will perform different studies depending on our research interest or the population health interest, such as observational epidemiological cohort studies, population impact studies and project appropriateness, economic evaluation, decision support tools for continuous improvement of the clinical practice. This could be included in the stage 4 because it's more focused on patient health, but we include it here because it's more for a global application to the patient cohort, and develop of predictive models and learning algorithms. We have developed as well, and we'll show a more detailed list of this in the next slide, a series of archetypes of professional profiles. We wanted to represent here in the upper part the 5 more important professional profiles that are, in our understanding during this year, is the clinical leader is the most important. The managerial leader is very important, especially in the beginning and at the end of the implementation. The data scientist and the data manager, and also the project coordinator. As you can see, these professional profiles or these skills and capabilities are the main drivers of the costs. We have in the bottom part of the figure, we have defined a tool for estimating the resource allocation. And we have made so because we are a public hospital, so we are health providers, but also we are payers of the service. So the way we can pay or we can measure our costs more simply in these cases is just understanding how much is the cost per professional. Some costs are lost because we don't include here, for example, cost of the ICT tools or cost of any other tool that you need to implement, but we are charging them in roles like process engineer analyst or epidemiologist or data scientist or case manager or ICT engineer. So we use the salary or the cost of the professionals to calculate the global cost of the projects. And here we didn't put the euros here because really the reference is lost. It would be a cost for Spanish level of life and also in euros. So we decided to talk about persons per year or in high and lower complexity projects or percentage of adjusted budget. The adjusted budget is telling you how much are you going to spend in medical condition leaders' time spent in the project, managerial leaders or communication managers, within the project. You know, if it's one person per year, it could be 24.31% of the total budget. For example, managerial leaders and data manager and case managers are considered not essential, because in fact we do have projects without these roles. So we haven't inputted a cost to them, a percentage of the cost. If they work, they will have this cost, and we have developed this budget as well. And if you want to see it, you have my contact. Okay, as I say, here is a more detailed definition of the professional roles that are important for these projects. I'm not going to go into detail, but some of them are essential, others are advisable. It's good to have them, but it's not necessary. And they have to have some skills and competencies, and they have to develop some tasks and responsibilities. When I explain this part, I used to say that this is a work for the middlemen. Is these people that have a mixed profile, you know? It's not that you need to have a communication manager exclusively dedicated to the project, but you could have a professional with, I don't know, quality of care skills, and also communication skills, or a data manager with informatics skills. So they can talk each other languages. They can talk the language of the clinicians or the nurses, and the informatics or the engineer talk, or the quality vocabulary. So they understand each other this way. So here is what we have collated during these years. I must say thank you very much. Thanks for watching. I want to say we are at your service. I leave here my contact information. If you feel like giving feedback or asking questions, you can either write to me or leave a comment on the video. There are several people related to this work that would be very happy to answer your question, including me, of course. In the video description, you have a link to the PDF of the poster, the abstract sent to the meeting, and an article regarding these issues. We do appreciate your interest, and just wanted to remember you, as Avedis Donavedian used to say, that ultimately the secret of quality is love. So thank you very much. See you soon, and thanks for watching.